Hello, everyone. Welcome to our Zoom meeting. Today, we will have different topics. We will talk about the green team, and Dr. Sofian will lead his team, Suleman Sofian, and we'll start with sharing experience with Dr. Zeinab. Mohammed, please, congratulations first of all for securing a position as a resident. And I'm gonna hand it to you. You can go ahead, Dr. Zenit. Thank you.
Thank you so much, Dr. Nader, for giving me the opportunity to share my experience and to show how all your help with me was like, again, um, what you did with me. And for the all of the fellows, my name is Zeinab Muhammad, and I'm one of the old graduates. I did my residency in Sudan and then moved to the US. And I joined the Telegeriatric Research Fellowship since 2023. And I have applied for residency twice, but unfortunately I didn't match. But alhamdulillah, I matched for nephrology fellowship uh, this year at Detroit Medical Center. And I would like to speak how the Telegeriatric Fellowship Research Program helped me in achieving this position at Nephrology Fellowship. Actually, Telegeriatric Fellowship played an important role in supporting me during my fellowship application process. Through it gave me a continuous learning and kept me engaged academically. As every one of you, I was a part of both learning groups and research groups where I received guidance and mentorship and encouragement through the process. And through these groups, I was able to connect with colleagues who were I also applying with them the application of residency and fellowship. And we supported each other and participated in interview questions together. And these groups helped me feel more confident and prepared through the interviews. And the most important thing is that I received a strong letter of recommendation from Dr. Nader, Jazahullah Khair, which were very important in strengthening my application. And also, I get the opportunity to attend the intensive internal medicine review course at Cleveland Clinic twice through this fellowship when Dr. Nader helped me with a fellowship letter that I'm a part of telegeriatric fellowship, and I get the opportunity to attend that course. And another thing that this telegeriatric fellowship, during my interviews, it was a strong and unique point. I was able to discuss it and speak about it confidently. I have been asked about what do you do in a telegeriatric fellowship research program. And I was answered them that we have weekly presentations covering a wide range of geriatric topics and participating in research groups, including working on proposals and abstracts and all these research things. And I keep myself updated in medicine through these weekly activities, and also I get the opportunity to attend intensive courses in revision of medicine for the board exams and like this. So all these things like kept me updated in medicine and well prepared for fellowship training and like this. So it was a unique point of discussion during my interviews, really. And again, I would like to thank you, Dr. Nadir, so much for giving me a part and allowing me to be one of these telegeriatric research fellowship, because actually and honestly, it's played a very big role in achieving this position.
Thank you so much, Dr. Zainab, for sharing your experience. I'm going to open the floor for any discussion or any questions.
Yes, I'm here.
So my first question for you, when you applied to the fellowship,
Mm.
did you do mock interviews in
Honestly,
preparation? Mhm.
honestly, for fellowship interviews, I didn't. I didn't do mock interviews. Uh, I was just because during my application to the residency, yes,
So you
in
had
our
experience
groups,
with, how
yes,
did you do it?
yes.
Yeah,
So for this application for fellowship, I didn't. I just use what I did before during my applications of residency, which I didn't match. So I uh, I took the benefit of those past mock interviews.
sounds good. Can you just elaborate on the mock interviews? How did you do it with your other fellows? Thank you. In your group.
Okay. Um, I didn't get the question, Dr. Nadir.
So can you just tell us more about how you connected with other fellows and started working like your, when you prepared for IRAS, the mock interviews, how did you do that?
Actually, in the telegeriatric group, each group, like I was in the golden group, each group have one of them be the coordinator or the interviewer, and the other be the interviewee. And we have those questions, the common questions, and each one asks the other, and then they give you the feedback. So this thing, like I get the benefit of these feedbacks because it was a very good feedbacks, which I could review them again and try to make it better and better through taking these feedbacks.
Sounds good. And how did you find out about the infectious disease? You are going for nephrology, right? The
Yes,
nephrology
yes,
fellowship.
yes, correct.
How
I'm
did you
going.
find?
Um, how did I find the nephrology?
Mhm.
Okay, there is a list of fellowships names which are like giving chances for um, foreign graduate and IMGs. So I just applied on those one, and I have the
Great.
list. I can forward it if anyone want them. I can forward the list.
Yeah, that would be great.
Okay.
Thank you.
You're
Any
welcome.
questions for Dr. Zainab?
I have a question if that's okay.
Yes.
Yes, Dr.
Okay.
Lina, go ahead.
Hello, Dr. Zeinab. I hope you remember me. I contacted you before regarding an observership in Chicago. So first of all, congratulations for the fellowship.
Thank you.
And I just wanted to ask, you said they mentioned the telegeriatric research fellowship in the interviews. How
Yes.
did it come? Did they ask like specifically about the projects you're involved in or the projects you finished? And do you think like the number of projects you worked on added much, or did they ask about like the numbers of presentations you went through? Like, was it a detailed Just like give us like an overall, I don't
Okay.
know, like preview
Yes.
of the things
Okay.
that we should focus on and that you think really, really like had a big impact on your interview.
Okay, get it. Well, in my case, yes, almost all the interview which I did with them, they had asked me about this telegeriatric research fellowship. As you are applying for nephrology fellowship, why you are putting this in your CV and what you did in this or what you do in this fellowship. So they give you what you want to say. They are not asking about much details. But I used to speak about I'm not clinically active, so this telegeriatric research fellowship it's an online program which allow me to like keep myself updated in medicine, even if it's we are speaking mainly yes in geriatric topics, but still it keep me updated in medicine. And also another thing, yes, it's a telegeriatric research fellowship, but it's not just about researches. And also, as I spoke earlier, I told them that it gave me an opportunity to attend like more invasive and intensive medicine review in Cleveland Clinic. So this it's giving me more points about this program, and it is just about geriatric population or research just. So they had like a picture about the program, and it is not just about research or just about geriatrics.
I see that. That's really good. Thank you so much and congratulations once again.
Thank you.
Thank you once again, Dr. Zeinab. I think also we have Dr. Mohammed. He also was matched. Dr. Mohammed, if you are here. Maybe he's not available yet, but I'd like to thank you so much, Dr. Zainab, and congratulations again. And if you have any other tips down the road, if you, when you start, you find anything that positive that we can share in the past, like people work on projects and got other fellows involved in the same project that they are working on, maybe you can do the same. And just remember there are other fellows that may benefit from your connection there as well. And we wish you all the best. So thank you so much for sharing your experience and your
Thank you
tips.
so much, Dr. Nader. And of course, if anyone have any question, my email is there. They can send me any message and I will reply. And also, I can send that list of the fellowship application to everyone. Thank you again, Dr. Nader.
Thank you, Dr. Zainab, and we wish you all the best.
Thank you so much.
Yeah. So we're gonna move on to the topics. Dr. Muhammad will not be available for another couple of minutes. Maybe Mohammed Makkawi. Maybe you can start with um, poster presentation if Dr. Bayadir is available.
Yeah, sure. I don't mind starting.
Thank you so much.
Okay.
When you're
I
ready.
would just like to share my screen.
Yes, please.
Okay, is it clear? Can everybody see?
Yes.
Okay, so hello everybody. My name is Bayadir Adam, and today I'll be presenting to you just a brief outline on how to design an effective research poster and present your findings at conferences. So some essential steps for effective poster presentations. So this presentation will just outline the key steps that are necessary for creating a compelling research poster and how to effectively present findings at conferences with a focus on needs and interests of medical audience. This is something we all have to deal with, whether it's at like medical student level or even postgraduate. So it's very important for us to be aware on what makes a poster effective. So essentially, why do research posters matter? So research posters communicate research efficiently. They offer opportunities for feedback and collaboration, as well as encouraging networking with clinicians, researchers, and program directors. And they enhance CV and residency applications. So the key principles of a good research poster include clarity over complexity. You don't want to overcrowd and overwhelm your reader. You want to make sure to present your points in a way that are clear while outlining all the important points that you want to address without them being too complex, as well as visual hierarchy. You want to outline your points in a way that they flow visually to guide the reader's eyes. You want to make sure that you use concise text, but and as well as strong and engaging visuals rather than, again, using a lot of boring, like long paragraphs, long text. And also making sure that you have well-organized sections. And at the end, obviously, you want to be able to have a take-home message to summarize all your findings to the person you're presenting to. Key parts of a scientific poster include, so as you can see in the diagram, so you have your content. You only want to include information that supports the take-home message of your research. The layout, you want to make sure that your poster sections have a logical visual flow with ample white space between elements. Typography, so you want to choose large font sizes so that the text of the poster is easy to read. Colors, you want to help the viewer make contrasts by choosing colors carefully. Images and illustrations, so you want to use good quality images with high resolution. And then finally, number 6, design, you want to choose one design tool to avoid formatting errors. So this is an example of a good versus a bad poster. So the second one is something is what we would consider a good poster. So first of all, the flow of information is very clear. You're guiding your reader from top to bottom. You're using visuals that are clear. You're not so the text is concise. You're not overcrowding your sections with unnecessary information, as opposed to the second poster where you can see that. So here, the text is very crammed. It's too small and it's too much. Your reader cannot even really read it from a distance. The captions are not aligned with the figure. And the text dissolves into intimidating, boring gray. So these are all things that you want to avoid. So the first step in preparing a research poster is the planning and structure. So these are a few steps that would help guide you in planning the structure of your research poster. So first of all, you want to know the rules. Generally speaking, when you want to present to any conference, they will usually have the guidelines on their website or like when you submit your poster to them. So you want to make sure that you always check those guidelines for the specific size that they want, the orientation, etc. And obviously, if there is some sort of competition that you're entering, you want to make sure you check the criteria as well. Number 2, you have the 10-10 rule. So in the 10-10 rule, you want to assume the attendees look at your poster for 10 seconds from 10 feet away. So from 10 feet away, if someone looks at your poster for 10 seconds, they should be able to to read your title, as well as know your main findings from that distance. Number 3, you want to keep it simple. As I said, you want to focus on 2-3 key findings rather than trying to present all your data to avoid overwhelming the viewer. And follow the IMRAD structure, which, so this is a clear outline for the poster. You have the introduction, starting with the introduction name, obviously after your title, your institution name, the authors, etc. So you want to start with your introduction and aim. You could also include an abstract, but not all posters include abstracts. So in the introduction and aim, you want to briefly define the research gap and your hypotheses. And then you move on to the method where you want to make use of flow charts or bullet points to make it easy to read to your reader, and you want to avoid unnecessary detail. And then you move on to your results where you want to, again, very concisely outline your most important findings. This is actually the most important section of the poster. This is where you present your important findings. So here you want to again make use of visuals instead of text in order to show specifically quantitative data. So bar charts, pie charts, line graphs, etc. And then finally your discussion and conclusion. Sorry, that's supposed to say conclusion. So clearly here you want to state the outcomes and their clinical impact, and also your takeaway message is usually going to be there. So when it comes to design and how to design the poster, so first of all, effective design principles that are going to help enhance your readability and engagement in research posters include, number one, you want to make sure that you use less text and more visuals. So a general good rule of thumb is you want to make sure that you use about 40% graphics, 20% text, and then 40% white space. As for font size, again, this may differ depending on maybe a specific conference outline or requirements, but generally speaking, your title should be at least 85 to 120 points. It should be readable from a distance. Your headings should be 36 to 48 points, and then the body should be at least 24 points, again, to ensure readability. Number three, color strategy. So you want to stick to 2 to 3 colors. Use dark text, or preferably use dark text on a light background for maximum readability. Because again, remember our rule, you should be able to, your reader should be able to read your title and know what your main findings of your research if they look at your poster from 10 feet for 10 seconds. So that's why you want to make sure that you use a font and a color that is readable. You want to avoid clashing colors and ensure high contrast. And then finally, flow. So you want to organize text in logical columns, typically from top left to bottom right. So generally speaking, there are many tools for poster creation, but the most common would be PowerPoint. Canva is also on the rise. A lot of people have been using Canva. And then Adobe Illustrator. But most commonly, it's PowerPoint. So when it comes to presenting your poster, once again, you have the 2-minute the 2-minute pitch. You want to develop a brief 1 to 2 minute spoken summary. So the structure of that summary should include 1, the problem that you're addressing, 2, what you did, so essentially what your research is about, and then 3, the key results. You want to avoid all the fluff. You want to make sure that you only mention the results that matter and the significant outcomes, and why this topic matters in terms of research. So for example, you could, so an example of this brief pitch could include, this study evaluated X in Y population, and we found A significantly improved B compared to C. So these findings suggest potential implications for clinical management of Z. So we're stating the problem. So what we studied, we evaluated X in Y population. You want to make sure that you always mention what you studied and the population. And then you want to, so what you did, so we did this and we found A significantly improved B, so that's our key results. And then these findings suggest implications for clinical management of Z, so why it matters. Number 2, you want to be engaging. So stand at the side of your poster so you don't block it, and smile, maintain eye contact, appear confident, and then allow people to look at the poster first before you start presenting it. Prepare for questions. Once again, anticipate questions about your methodology, limitations, clinical relevance of your findings. Now I'm going to discuss, so we discussed that the main tools used include Canva. So I'm going to discuss just a brief step-by-step on how to use Canva to make a research poster. So first step, obviously, you want to go to canva.com, or you could use the application, especially if you're using it on like a tablet / iPad or maybe your phone. So step number 1. So first of all, you have to select that you're choosing to actually make a poster or a presentation, or from the selections that they'll have available. So after you choose poster, you want to go to templates, and you can type up. So as you see here, I typed up medical poster. To like browse and look for a suitable template from the variety of professionally designed templates that they have. They have a lot of options, so you can choose one of those, or you can choose to create your own one from scratch. And then you can customize the poster based on your preferred poster size as well. So again, depending on whether you want it to be A2, etc., you can customize that there. Then from there, you want to customize the design by editing the text, the images, and colors to align with your research content. So you go to You can customize text by going to text. You can also go to elements to customize further there. And then in step 3, you can add visuals such as charts and graphs to make the poster visually engaging and informative. So you can then go to apps, to charts, you can add photos. You can even add voiceovers, anything, like if you want it to be digital, etc. And then finally, you want to finalize the design and download the poster in your preferred format for presentation. So once you're done, you go to the top right corner, you go to share, then you select download, and then here you get the option of whether to download it in JPEG, PNG, PDF, whatever format you want to choose. It's very easy to use, very helpful, and it's very, you can make posters very quickly on Canva. Now, conclusions and takeaway points. So it's very important that you understand your audience. So you want to recognize your target audience, which is going to allow for a tailored message and design, increasing engagement and comprehension. So for example, if you're presenting to a medical student, it's not the same as presenting to a physician. You want to simplify the information to the medical student while you want to maybe like give a more clear or like the more clear, complicated version to the physician instead. You want to focus on design. So you want to make sure that you have effective design, which is going to emphasize the clarity and the aesthetics. It ensures that the key information stands out and is easily digestible. You want to practice your presentation skills. Now, this is it's just as important as the poster itself. How you present the poster, how the information comes across to the reader. It's really going to depend on your presentation skills. So you want to make sure you practice your presentation skills. You want to make sure you're confident and you engage with your audience during your presentation. Any questions?
Thank you so much, Dr. Bader, for great presentation. So this, I think, one of the skills that every one of you should know. And with COVID, the posters become like another version where people will present virtually. So you have to be able to present either in person or online when you are presenting in a conference, for example. And these skills also will accompany you. Like for Dr. Zeinab, when she joined the nephrology, most likely she is going to work on project and present in conference, or even just to present topics in the fellowship itself. The one that point I want to add is that sometimes you may have templates. So in our program here, we have some templates, so you can use these templates. You modify whatever font, color, etc., and then you add your text. And as Dr. Bayadir mentioned, then you want to practice and make sure you know your project from A to Z, just in case they ask you anything. One thing that sometimes they may ask and you might not find the answer, you will tell the person who asks you, I'm gonna find out and I'm gonna get back to you, and you take their contact information, email also. This in big conferences, for example. Most of the time they will ask you, what's your next step, for example, after you did your, so you will say, our next step, we are going to form a team to study this and that, or if you don't have an idea, then you can say, we will get back to you. But thank you so much, Dr. Badir. One thing you can look at is other people who presented in this fellowship, like in conferences virtually. So you can look at the posters when they present it. Usually they will record themselves and tag that in the poster itself, and people will look at the video, and if there is any questions, they can contact the author. Any questions for Dr. Badir? Great work. Thank you so much, Dr. Badir. And this is very useful.
Thank you so much, Dr. Nader.
Thank you.
Thank you, everybody.
Thanks. If there is more questions, we can move on to the next topic. Dr. Mohammed Makkawi, when you are ready, we can talk about dentistry. Thank you.
Hello everyone, my name is Dr. Mohammed Makkawi. I'll be presenting about dentistry. Just let me share my screen. Okay, I believe everybody can see my screen, right?
Yes.
Okay. So, hello again, my name is Dr. Mohammed Makkawi. I'll be talking about dentistry and oral health. Well, as most of us here are doctors, so you may see that why are we learning about this topic, but I believe that it will be interesting to learn to expand our horizons and learn something outside of what we're used to learn every single day. So let's get started. So here mainly we're going to talk about the normal age-related changes of the teeth, gums, and glands, and and the significance of dental caries and periodontal disease, and counseling about dentures, proper management of dry mouth, how to identify oral and address oral cancer and their problems, and what are the changes that occurs during aging in general. Okay. So the main dysfunctions of the teeth and the mouth. So why is it a concerning issue? Well, actually, the mouth. That's why it has its own specialty in medicine. It's called dentistry, because it by itself affects overall health and social functioning of an individual. Like almost every celebrity you actually uses their teeth as form of their branding. It's that important for their social functioning. And this is especially important for those who are frail or nutritionally at risk, or elderly, those who are at risk of malnutrition. And mainly thing, and many, you have seen many patients, I'm sure, especially in the elders, they may have some missing teeth or decayed teeth with salivary hyperdysfunction. So it's especially in the geriatric population, oral care is very important. We will talk about it more in details. And it's important to emphasize that it's not normal to have such problems in the teeth, and it's important to encourage preventative and therapeutic care. So some basic anatomy of the teeth. So the outer layer is known as the crown, which is at the top. Below it is the enamel, and then the sensitive part, which is known as the pulp, which is deeper inside, which has mainly the nerve roots. Then you have the gingival mucosa, the roots, and this is all held by the cementum, and then the ligament, and then you have the alveolar bone, which is just below the root of the teeth. So, what are the age-related changes that occurs in oral tissues? First, we have something known as tooth dentin. Here there is diminished pulp space due to the increased thickness of the outer layer, and this will lead to decreased permeability, so which will cause sclerosis of the dentinal tubules. This will make the teeth more susceptible to bacterial infection and increase tooth brittleness. It's just like the teeth version of Paget disease of the bone, where even with Paget disease of the bone, even though there's extra mineralization, the teeth becomes actually more brittle. Then there's the dental pulp. The main issues that happen when it's decreased volume, and this will really decrease the reparative ability of the teeth when it's exposed to sugar or acid, and it will also make the teeth less sensitive to pain or and then uh, f- we have the salivary glands. The common issues happening is fat when the acini is replaced by fatty tissue, and this will lead to less physiological reserve of the salivary gland, which may lead to dry mouth. Then the dental caries, which is the most common that affects teeth. Here, this is caused by bacteria, which cause demineralization and cavitation of the teeth, and this can continue over the lifespan.
Okay.
However,
Yes, they are
yeah.
doing EKG for.
Sorry about that.
However, it's okay. However, about this occurs throughout the lifespan of a person. That's why it's important to continuously brush our teeth every day, at least twice a day. And this is more commonly seen in elderly patients because they normally have less regenerative ability of the teeth. And so it's more important to focus on the elderly regarding oral care. So the thing is, both of them, either recurrent or through caries, both of them are asymptomatic. So he may not have any pain or any problems with chewing, but it can be advanced until there is nothing left of the teeth. So the teeth can be destroyed and nothing will be left of it, and still he may not have any symptoms. Hence, regular oral care is very important. So, when there is advanced dental decay, this can cause necrosis of the remaining pulp if it's not treated, so which can lead to dental abscess. Yeah. Even if it's not painful, it has to be treated, otherwise, because it's still a source of infection. And strep viridans is known to be cause one third of the bacterial endocarditis cases in the U.S. Hence, previously it used to be a strict protocol that any patient who's undergoing any oral treatment were required to take prophylaxis, but recently it has been amended. So, what are the risk factors? Of course, number one is poor oral hygiene. Either, especially in the elderly, one of the main causes could be due to decreased impaired acuity and difficulty in maneuvering even with the toothbrush. So he may not be able to brush his teeth well, or they could diminish salivary flow. The saliva, actually, one of the main functions of saliva is to protect the teeth from decay. Then, of course, as young, we have been always instructed not to eat a lot of sweets. So this is one of the main causes of dental caries. And this is something that's actually common in not just in the US but most of the world. Lack of dental insurance. Then usually in jobs, insurance don't normally cover dentists as well. So most of them avoid having frequent follow-ups with the dentist due to its a huge expense. And many people have the perception that it's not really important as long as we just brush our teeth. There is no need to have a regular checkup. Then for those, some people, they may have artificial teeth. That also can be a risk factor. And then limited lifetime exposure to fluoride. Addition of fluoride in drinking water has been one of the most successful public health interventions that has occurred in not only in the US but in the world, and this has led to a significant decrease in dental caries incidence, especially in children. How to prevent it? Well, as we said, daily oral hygiene, at brushing at least twice a day with fluoride-containing toothpaste, and cleaning between the teeth is really important to prevent dental caries, and limited exposure to sugar, as well as regular dental examination. So let's say somebody developed dental decay, what can be done? Well, there are topical high potency fluoride that can be given for remineralization. The dentist usually can provide such prescription for it. And then if there is some decay, then you can then this demineralized tooth structure can be removed and replaced with fillings. And then if it involved a pulp, then it may need then root canal treatment will be necessary. And routine professional dental care actually includes prophylaxis and topical fluoride applications. This can also help further prevent dental caries. Okay. Now we'll talk about another disease, periodontal disease. Periodontal disease usually involves the gingiva and the alveolar bone and the periodontal ligament, which is a sieve that covers the between the tooth root and the surrounding bone. So this occurs when bacterial colonies form on the teeth between near the gingiva or the gingiva and the root surface. The problem is with plaques. Plaques in general are very soft and they can easily be brushed off. But if it's not removed, it can harden and become tartar or calculus, which acts as a further irritant to the gingiva and it's more difficult to remove. Then gingivitis. This is the inflammation reaction to plaque, and it is limited only to the gingiva. And normally this is reversible if you remove the plaque. However, periodontitis, which is the inflammation that extends towards the ligament and alveolar bone, is not the damage it is treatable, but the damage that has already occurred is irreversible, and this will destroy hard and soft tissue of the periodontium. So, what are the risk factors? You have advanced age, smoking, and poor oral hygiene, and commonly in Sudan, the tobacco snuff saud is also very common cause of periodontitis. Interestingly, Black and Hispanic Americans have a significantly higher prevalence of advanced periodontitis than white Americans. This could be in part due to difference in access, like white Americans may have more access to dental care compared to Black and Hispanic. But that's one side of the story. Partially, it could be also due to genetics, but it's not just because they're black. It could be also due to social reasons of access of care. Okay. So how it is managed? It's managed by removing the plaque and tartar in the teeth and root treatment below the gingiva. It's called deep cleaning. Many times it may require local anesthetic, and sometimes require surgical access if it is very deep. Topical antimicrobials like chlorhexidine oral rinse can also be given at the same time. Rarely, if it's really deep, it may need systemic antibiotics. Okay. So edentulism. Edentulism means missing teeth or someone not having any teeth. Interesting statistics, in the 1960s, more than 70% of Americans above 75-year-olds were without teeth. But recently, in the 1990s, fewer than 40% of Americans were without teeth, and currently less than 25%. So why is it a big issue? Because one of the main functions of the teeth is actually maintaining the facial structure, the structure of the face. So when someone loses their teeth, the shape of their face actually changes. So they may not be the same as before. And also chewing ability obviously will be severely compromised, since that's one of the main functions of the teeth. And of course, nutritional intake will be impacted, since they will be forced to take, since they can't eat any hard food, they'll be forced to take just soft food, which can lead them to develop nutritional deficiencies. So one way how to treat it is removal dentures. You might have seen in cartoons where an old man will remove his denture, entire teeth, and puts it in a glass of water when he sleeps, and then when he wakes up and puts it back. So that's actually used, and this can be used in speech and can help in restoring the facial contours. It's still not very predictable on will a person be able to chew well with it or not, and may require continuous adjustment. And sometimes you can use adhesives to hold it properly, but it should not be used as a substitute for poorly fitting dentures. Finally, then there is the dental implants, where you can actually implant teeth. However, this treatment it may not appeal to everyone. So how do you care for dentures? We have to, whenever someone eats, we should remove it and clean it after every meal. And there are over-the-counter denture cleaners that can be used. And it should be removed for several hours every day. And overnight, it has to be removed. Then you should always see a dentist if it's fractured or broken, or the dentures are loose, or they cause soreness when applied. Then we have the salivary function in aging. It is important, one of the most important functions of the salivary gland is to protect the teeth from dental caries. So normally when somebody age, the salivary glands undergo regression with histological changes. However, it has been shown that the production has not decreased significantly and is essentially the same as long as someone is aging healthy. By extremely old age, then the person may develop other conditions that can lead to impaction of salivary gland function, such as dehydration or drug-induced hypofunction, which we'll talk about more in the next few slides. So what are the causes of dry mouth? There are, of course, multiple medications. The most common ones are the anticholinergic or antimuscarinic. They are the ones that are greatly implicated to cause dry mouth. You have like, especially those that are given for urinary incontinence, tricyclic antidepressants, opioids, antihypertensive, antihistamines. Some diseases, such as salivary gland tumors or blocked duct. Certain systemic diseases, such as Sjogren's syndrome, depression, hypothyroidism, can also lead to decreased production of salivary gland, leading to dry mouth. Then head and neck radiation, especially those who undergo treatment for Hodgkin's lymphoma, are famous cases of examples of patients who develop dry mouth later on. So how do we manage it? If it's caused by medications, we'll have to find a way to either decrease its dose or substitute it to use alternatives. So then there are medications that can improve salivation, such as pilocarpine. Then over-the-counter salivary substitutes can also provide some transient relief. And for those who are high risk of oral disease, we have to counsel them to limit their sugar intake and optimize daily oral hygiene and have more frequent dental examinations. Okay. So there are some few common oral lesions: oral cancer, exocysts, geographic tongue. We'll talk about each one of them. So their oral squamous carcinoma, they actually have many types. As you can see here, the one that is marked C, which is the erythroplakia. That's one of the earliest, that's one of the most important feature of an oral squamous cell carcinoma. And this is another picture of it. Then you have exostosis. This is the black parts that you can see in the teeth. So they're called torus, if it's one, or tori, if they're plural. They develop in the palate and the lingual aspect. And they grow slowly, and sometimes they can be very difficult to eat if you're having them, and can cause a lot of pain. And they can develop, they can cause problems when you're applying dentures. Then there's a geographic tongue. Here you can see these black spots, black lines. Here they show the dorsum of the tongue displays irregular patterns, just like a map. That's why it's called called geographic tongue, due to hyperkeratosis and denote the reddened areas lacking lingual papillae. And this pattern can change. However, it's important to know that this is just a change in the shape, but it's not something to worry about. Then oral candidiasis, which is also like oral thrush. It can present as diffuse erythematous mucositis, cracking at the corners of the mouth, with curd-like white patches and erythema in denture-bearing areas. And it can be asymptomatic or result in a taste dysfunction. And it is important that when we ever see a patient with it, we should exclude any immunopathic cause. Like it's common if anybody has any type of immunosuppressions, such as HIV, one of the can cause oral thrush, and it's important to exclude them. The poorly controlled diabetes is also another cause of oral thrush, and this is usually managed by topical or systemic antifungal. So topical usually it could be nystatin wash, the mouthwash that you just swish and swallow and spit, and of course optimal oral and denture hygiene. This is how it looks like. It's important that to know that in the candidiasis, the white spots they can be scraped out. Unlike the other condition that we'll see later, leukoplakia, which cannot be scraped off. Herpes simplex is a virus that affects the trigeminal ganglion, and it usually appears in the form of small clusters of small red rimmed, and they're it's important to note they're highly contagious, and usually they're just limited to the palate and gingiva with the extraoral portions of the lip. And it is important to distinguish it from abscess ulcer. Usually abscess ulcer will be one single lesion, and it will form only in the movable oral mucosa, like in the inner aspects of the cheek and floor. And it has different risk factors. It's mainly either smoking, stress, or certain vitamin deficiencies can lead to abscess ulcer. So this is how it looks like. You can see that it's multiple circular lesions. Then we have hairy tongue. Usually the tongue, just like any form of epithelial tissue, continuously grows and sheds. So in the tongue, when this formation does not occur, it will lead to elongation of this papilla and it will cause the appearance of hairy tongue. And the problem is this can serve as a substrate for bacterial or fungal growth. This is a picture to show how it looks like. So this can serve as a reservoir for growth of fungal and bacterial growth. Then there is a burning mouth syndrome. It's actually an idiopathic cause. It's just an chronic oral facial pain disorder. There is no other clinical signs, and commonly known to affect women above 50, especially in Asian Americans. And many causes have been suggested, like xerostomia, dental use, candidiasis. And here the treatment is just symptomatic, since most of the time we are not sure what is the cause of it. Then traumatic ulcers. This usually when someone has a broken teeth. So continuously this can cause a sharp edge which continuously injures the inner lining of the mouth and can cause injury. And this lesion should be identified, and if not resolved, then biopsy may be considered, because an not healing ulcer is considered cancer unless proven otherwise. So there are many types of oral malignancies. They can appear as painless red, white, or mixed red and white. So we just showed you earlier the picture of erythroplakia. Here it's red or mixed lesions. They are present in as many as 93% of the cases, and they definitely require biopsy. Leukoplakia are malignant about less than 10% of the time, but it should be at least have close monitoring. And if it's not healed within 14 days or increasing size, biopsy is warranted. Then we're going to talk about olfactory function. It's important that flavor is caused by a combination of both sense of taste, and sense of olfaction. So if either one is affected, it can affect the sense of taste. And olfactory sense functions actually declines with age, and they tend to affect men greater extent than women. And anecdotally, it has been implicated as a risk factor for eating spoiled food or failing to notice gas leakage or domestic fires. So taste reception, when there is affection in taste reception, there will be the effect of the perception of saltiness and sweetness. It gets blunted with advanced age. which of course has clinical significance as it makes the person oversalt his food or crave sweets all the time. Some drugs may have no primary effect on taste, but cause diminished saliva flow, which saliva as well is important for taste perception, and with its decrease, it can impair taste perception. So, what are the non-pharmacological causes? Oral causes such as burning mouth, candidiasis, malignancies, salivary hypodysfunction can cause taste dysfunction. Other causes like Alzheimer's or any neurodegenerative disorders, CNS tumors. Some toxins, they can affect the smell, while certain endocrinopathies such as diabetes can affect the taste. Famously, head trauma can cause both smell and taste dysfunction. Nutritional deficiencies such as B12 and niacin, and stroke. Then upper aerodigestive respiratory causes such as sinusitis. You may have experiences when you have any stuffy nose. You may realize that your ability to taste food actually decreased. So like I said, flavor is a combination of both the sense of smell and taste. So with stuffy nose, you may not be able to taste as well as you used to do before. Other causes are tobacco smoking, nasal snuff, any tumors, anything that affects the airway can also affect the sense of taste. Then what is the relationship between oral health and general health? So, periodontal disease actually has been linked epidemiologically and immunologically with coronary artery disease, peripheral vascular disease, cerebrovascular disease, pneumonia, and those who have proper oral improved oral health has been shown to have significantly reduced incidence of institution acquired pneumonia, reduced mortality, and reduced length of stay in hospitals. So, what is its relation with diabetes? Usually, periodontitis is worse in patients with poorly controlled diabetes and as a cause of chronic inflammation, and can also, and this itself as a cause of chronic inflammation impedes effective control of diabetes. And periodontal disease also negatively impacts glycemic control due to the inflammation that cause increased blood glucose. And those who have poorly controlled diabetes have more severe periodontal disease, as hyperglycemia can decrease the ability of the body to kill bacteria. And the hyperglycemia can also lead to increased glucose in the saliva or the cervicular fluid around the teeth, which can serve as further feeding for the bacteria. And for cardiovascular disease, there could be due to direct infection from the oral bacteria that can cause an inflammatory response and lead to plaque formation in the blood vessels. Some periodontal pathogens can cause platelet aggregation, can result in clot formation. Then let's talk about some medical considerations in dental treatment. About 1/3 of reported cases of infective endocarditis caused by organisms that are found only in the mouth. So those who are at elevated risk of endocarditis should be counseled to optimize their daily oral hygiene to limit gingival inflammation. Prophylactic antibiotics can be recommended, but only in specific high-risk situations. But previously, we used to give routine antibiotic prophylaxis prior to dental treatment, but this has been upgraded. So it's only those with high risk that they're given prophylaxis before dental treatment. And anticoagulants do not normally need to be discontinued before dental treatment, even for as very invasive dental treatment, as long as the INR is below or equal to 3.5, anticoagulation does not need to be stopped. Then there is also necrosis of the jaw. There are actually some drugs such as bisphosphonates. They have been associated with developing osteonecrosis of the jaw. And usually this will not occur in the oral doses. They are most famously occur in those who are receiving high high doses in through IV. Usually, those who are undergoing chemotherapy of the prostate gland, osteo bisphosphonate is given so that you can have better regeneration of the bone and decrease bone pain. So those who are receiving high doses via IV are at higher risk of developing osteonecrosis of the jaw. So the most important thing is that when you're giving this medication, is to advise that if you have any pain in the jaw, or if there is a sore or ulcer in the mouth that is not healing, it is most likely osteonecrosis, and he may not may require urgent dental care. So how to assess the mouth of the patient? So we ask about dental problems. When last time he had a dental visit, and does he have a dry mouth? And this is important to be work as a part of your assessment. And then perform an oral inspection during physical exam. But at least you should be able to know that it's not right. You may not be able to diagnose it, but at least we'll be able to know that this does not look right. So then in the elderly population, how do we manage long oral hygiene in the long-term care facilities? Here it's important that we're trying to disrupt the ability to form plaques, which accumulates in the teeth, and to check for any problems. Of course, brushing and flossing are ideal, but it may not be practical since flossing is difficult, especially in the elderly. So alternatively can be used like proxy brushes. They can pass through in between the teeth to clean and get rid of any debris. Power toothbrushes can also be used since they're easier for the patient and easier for the daycare for the carer to take care of their teeth. Then for those with dementia, it's important we have to be with them and to see what are we doing when we're trying to brush so that they can understand, see what's going on. And of course, we're going to use a toothbrush with a fluoride containing toothpaste to brush all the surface of the existing teeth and to spit out after brushing. However, it is not necessary actually to rinse your mouth, and sometimes it may be considered beneficial if you don't rinse, so that you can have more fluoride in the contact with the teeth. And before brushing, of course, you have to remove any dentures if present. So to summarize this long, lengthy presentation, as a person age, the teeth becomes less sensitive, and it's not uncommon to see profound yet asymptomatic untreated dental disease in older patients, which justifies the need for regular dental evaluation. Periodontitis is caused by plaque formation within the gingival sulcus, which can lead to loss of alveolar bone height, decreased support around the tooth, malposition, loosening, and eventual loss of the tooth. Dentures can help in speech and restore diminished facial contours, but improvement in nutritional status may not is still unpredictable. Oral cancer screening is critical to detect and treat of early stage oral cancer, since if they spread, it's very difficult. It's going to be very difficult to treat. The earlier you catch, the better survival rates the patient will have. Certain medical conditions can cause oral infections, so it's important to keep them in mind. Antibiotic prophylaxis can be given before dental procedures for those who are specific high-risk patients. And osteonecrosis of the jaw has been reported in 10% of patients who have received extended IV treatment of bisphosphonates. Usually those who have bone metastasis, bisphosphonates is given in the IV as they help in relieving bone pain. And this is usually common, like I said, in the IV. It's very much rarer in those who are taking oral bisphosphonates for osteoporosis. So go through. We have an 82-year-old man who has pain at the site where a maxillary posterior tooth was extracted 3 months ago by his dentist. He has a history of prostate cancer with bone metastasis and has been treated with zoledronic acid infusion for over the last 12 months. He has a 60-pack history of cigarette smoking. On examination, the extraction socket has not healed and the gingival tissue is open with bone protruding from the site. The area is erythematous with purulent discharge and foul odor from his mouth. What is the most likely diagnosis? Prostate cancer, osteonecrosis of the jaw, oral squamous cell cancer, or incomplete tooth extraction. You can post your answers in the chat. Okay, so the answer is B. As Dr. Wala said, it's also necrosis of the jaw. The patient have received IV bisphosphonates for over 12 months, and as we know, the IV bisphosphonates is a risk factor for developing osteonecrosis of the jaw. 66-year-old female with oral soreness, burning, and dry mouth that began 5 weeks ago. Her symptoms interfere with eating and speaking. She has a history of hypertension, diabetes, chronic hepatitis C infection, and depression. She is on propranolol, metformin, and sertraline, and she has been on this regimen for more than 2 years. She is scheduled to begin lepiravir, soposivir for hepatitis C in 2 weeks. On examination, the patient has multiple lesions consisting of radiating white lines with erythematous and erosive areas, and they're bilateral on the buccal mucosa and the palatal mucosa under removable maxillary partial denture. The lesions on the buccal mucosa cannot be scraped off. The anterior buccal maxillary and mandibular gingiva are erythematous with focal areas of desquamation that bleeds easily on pressure, and the mouth is generally dry. What is the most appropriate pharmacotherapy? Clotrimazole troches 5 times a day, acyclovir, oral pilocarpine, or betamethasone. Can you give your answers in the chat box? Okay, so we just went back. The answer is D. Yes, betamethasone gel. It can be helped to, this is to treat the symptoms, so to reduce the effect of the lesions. Okay. Now we have a 66-year-old man with swelling in the buccal gingiva of the tooth, number 20. 5 months ago, small mass in the buccal aspects of the teeth, number 18 and 19. These numbers are done by dentists to identify each teeth, so we may not know them, but it's all right. The lesion was removed and teeth 18 and 19 were extracted, and alveolar bone in the area was excised along with 27 regional lymph nodes. No evidence of cancer and did not undergo radiation therapy. He has a history of HIV for 22 years and diabetes for 10 years. He had osteomyelitis in his femur after radiation treatment for disseminated Kaposi sarcoma more than 20 years ago. And he has recurrent intraepithelial neoplasia for the past 6 years, treated with localized excision and laser ablation. He's on insulin, metformin, atazalanavir, ritonavir, and raltegravir. On examination, there is a firm non-tender enlargement in the buccal aspects of tooth number 20, wrapping around and extending to the edentulous space behind the tooth. The lesion has a mixed appearance of erythema and increased vascularity. Periodontal probing reveals a deep pocket in the distal aspect of tooth number 20, and the probe causes bleeding in the lesion. So, what is the most likely diagnosis? Diabetes related recurrent squamous cell carcinoma, recurrent Kaposi sarcoma, or osteonecrosis of the jaw. Okay, we have some D's and one B. So it's a recurrent squamous cell carcinoma. Well, because here the patient develop again, one of the features is that erythema, which is one of the key features of squamous cell carcinoma of the mouth. And that's all. Thank you very much for listening. Hope that you learned at least gain some knowledge from this presentation, and that you can use it in your career work, the everyday work. Thank you very much, and have a great day. If you have any questions, I'm ready to answer.
Thank you so much, Dr. Mohammed. If you have any questions, please go ahead. And if you have any comments or addition, Dr. Wala, if you want to add any
Yes,
notes or
Assalamu alaikum. Hi, this is a very nice presentation. I really enjoy it. Long time I didn't hear a presentation regarding the dentist. So I just have a small addition. So we need always in the old patient to ask regarding the medical history before start any treatment, because sometimes or most of the times we do have a medical problem. So we have to ask regarding if any heart disease, any diabetes, any blood thinner patient you are using in, because before we start any treatment in the dental unit, we need to go for this clearance, because sometimes we need to give the patient an antibiotic. It depends on the disease he's suffering from before we start the treatment. This is regarding the medical clearance. And also there is one most important thing in diagnosis, it's an X-ray. We have to go for the X-ray to go for the diagnosis, and then we will go for the clinical examination. And as the doctor, he said, we do have a multiple oral disease. It's most important thing, most popular thing in the geriatric, it's a root caries, because they're suffering from gingival recession during the aging, and then the tooth is going to be exposed in the gingival area. So this will affect the root area. So that's mean it's going to be, this is the root caries. And most of the treatment of the root caries, unfortunately, will go for extraction. If we need to go for extraction, we have to check the whole medical of the patient. And then the second most important thing for the adult patient is their stomia, dry mouth. So also there is a multiple medication related to the dry mouth. And we do have sometimes medication, we give them saliva substitute, and we give the patient sugar-free chewing gum. And it depends on the condition of the patient at that time. And also there is a periodontal disease as Dr. Makkawi, he mentioned above. And this periodontal disease, we have to keep the patient in constant regular follow-up every 3 months. We call it perio maintenance. We have to clean the whole bacteria from the socket. If we did not do that, unfortunately, the patient will lose his teeth. So if the patient loses his teeth, we will go for denture. And if we go for denture, it's going to be another problem. So most of the patients, they are using a denture, they're going to be under oral candidiasis. So because they cannot clean the denture properly, they make an injury every now and then. So in this case, the complication of periodontal disease will lead to extraction, will lead to denture is going to be oral candidiasis. And also there is the denture stomatitis. So there's a difference between denture stomatitis and denture and oral candidiasis. And also there is some patients suffering from angular cheilitis. This is an antifungal, an antibiotic ointment. We need to give the patient to treatment for that one. And also there is an tooth weird. So during the time and during the chewing and during the occlusal split, during the time the patient will suffering from tooth weird or adhesion of the tooth. So we are noticed in all patient, the length of the tooth is going to be smaller than the regular tooth, because this during the time there is a lot of patient, they are complaining about sensitivity, because there is a half of the tooth is gone, and there is a parts most sensitive area part of the tooth is going to be appear. So, and also there is burning mouth syndrome. The burning mouth syndrome is also related to what is called a dry mouth. I think that's all.
Thank you so much, Dr. Wala Farah.
Thank you.
For those who don't know Dr. Wala, she is a dentist and she is with us for some time now. So thank you so much for your input and we appreciate you.
Thank you.
If there are no more questions, we can move on to the next topic. Thank you so much, Dr. Mohammed, again, for a great presentation. Do we have Dr. Sofian? Dr. Suleiman, Sofian? If not, maybe we can move on to Dr. Malaz. Dr. Malaz Salah, welcome. Do you have any updates about your conference attendance presentation? Thank you.
Hello, Dr. Nader. Hope you are doing well. Actually, the conference was good, Alhamdulillah, and I attended and I presented like orally. And actually, all of the presenters, even so from the USA and so on, it was great. Even so, opportunity to meet like doctors from different countries and so on. Like it was a good network, Alhamdulillah. And I was literally feel proud, even so, like when I was talking about TGRF and so on. Yeah, Alhamdulillah. And most of them was asking me regarding like TGRF and so on, and regard our research projects and so on, and regard even so the like mobile app, how actually we are working, and even so we are follow innovation within our projects and so on. And that literally led me to feel more proud regard our working and so on. Alhamdulillah. And again, thank you so much, Dr. Nadir, for all opportunities and for all continuous support with us all of time. And let me share with you like the presentation.
So for those who don't know Dr. Malaz, I think you are in Kuwait or Bahrain?
Sorry?
You are located in the Gulf area in Kuwait?
Yeah, and UAE.
UAE, and she
Yeah, in Abu
presented
Dhabi.
the conference. What's the name of the conference again? Thank you.
Third International Conference, Healthcare Dubai, 2026.
Excellent. Thank you.
Is this clear, Dr. Nadir?
Yes.
Okay, firstly, actually, when I presented it, firstly, like I presented myself, and I was talking regarding like TGRF and so on, and Dr. Nadir and so on. And even saw like little bit starting with how like you can say IMGs is struggling with the fair drill knowledge and education and training and so on, and talking like regarding the gap and how it's actually like our project like working to feed this gap. And then I talk regarding the abstract itself. Like, I don't know, should I like presented it as? I don't have problem. Like,
Yeah, you can do the same what you did in the conference, just for
oh,
this
uh,
group so that they can know what's going on. Thank you.
okay. So firstly, I said, it's truly a pleasure to be here today, and I would like to thank organizers of the third international conference on healthcare, traditional and alternative medicine, Healthcare Dubai 2026, for this valuable opportunity to share our work. My name is Dr. Malaz Salah, and I'm presenting this project as part of Telegeriatric Research Fellowship in Michigan, USA, led by Dr. Nadir Abdurrahman at Michigan State University, where we work within an international team focused on developing practical and impactful solutions in real-world healthcare settings. And in healthcare, we are trained to respond to emergencies. We study protocols, we memorize steps, and we trust that when the moment comes, we will be ready. But the reality is often more complex because emergencies are not quiet, they are fast, stressful, and unpredictable. And in a fire emergency, with alarms going off, patients depending on you, and decisions needing to be made within seconds, there is no time to stop and think. There is only time to act. So the question becomes, is having the knowledge enough, or does effective response require something more? So something like clarity, confidence, and the ability to translate knowledge into immediate action. And this is exactly the challenge we observed, particularly in post-acute and long-term care settings, where patients are among the most vulnerable and where staff come from diverse training backgrounds, including many international medical graduates. And this observation led us to ask a very practical question: how can we move from simple teaching protocols to actually preparing healthcare professionals to respond effectively in real emergencies? And this is what led to the development of our project. So today I will be presenting our abstract, a mobile application-based innovation to educate staff on fire preparedness in post-acute and long-term care settings. And to address this challenge, let me walk you through key components of our work. Let me start with background. As we know, fire drills and emergency preparedness are not just regulatory requirements, but essential components of patient safety in skilled nursing facilities, where residents are often frail, immobile, and highly dependent on timely and coordinated staff response. And in such settings, even small delays or uncertainty in rules can significantly impact patient safety outcomes. And during a fire emergency, there is simply no time for hesitation. Response must be immediate and well coordinated. At the same time, international medical graduates represent a growing and important part of the healthcare workforce. However, many IMGs enter these systems with limited exposure to US-specific fire safety expectations, including regulatory frameworks, structured response protocols, and physician leadership roles. And in addition to that, the Centers for Medicare and Medicaid Services, CMS, require all healthcare staff, including physicians, to be trained under emergency preparedness role. However, despite these requirements, we observed that training is not always standardized, and more importantly, it does not consistently translate into real confidence or preparedness during fire situations. Therefore, the gap is not in the availability of knowledge, but in the ability to translate that knowledge into effective action. And based on this, our objective was to develop a structured, practical, and scalable approach to fire drill education. In other words, we aimed not only to improve knowledge, but also to enhance confidence, clarity rules, and support real-world readiness, particularly for international IMGs, international medical graduates working in skilled nursing facilities. And to address this, we developed a mobile application-based learning solution using a Glide app. The idea behind this approach was to move beyond traditional one-time training methods and instead create a more accessible and engaging learning experience. For example, the application allows healthcare professionals to access training anytime through their personal mobile devices, enables flexible and continuous learning. And in addition, the content is fully aligned with CMS requirements and include live safety code principles, as well as core response protocols such as RAISE and PASS. And moreover, it clearly defines physician, role during fire drills, along with interdisciplinary communication and documentation expectations. And to further enhance the learning experience, the application incorporates visual workflows, case-based scenarios, and brief knowledge checks. As well, as a result of this approach, shifts training from passive learning to more interactive, practical, and scenario-based experience. And in terms of methodology, the application was integrated into the onboarding and training process within the Telegeriatric Research Fellowship. Participants were required to complete the app-based module prior to engaging in fire drill scenarios. Following this, we assessed their self-reported confidence and understanding of fire preparedness. Specifically, we focused on rule clarity, response protocol, and overall readiness. This allowed us to evaluate not only knowledge acquisition, but also perceived preparedness in real-world situations. The results were highly encouraging. Participants reported improved understanding of CMS-defined fire drill expectations. And in addition, they demonstrated greater clarity regarding physician leadership and support role. Furthermore, there was noticeable increase in confidence when participating in interdisciplinary fire drill. And very important, the mobile-based format was perceived as practical and relevant, as it allowed learners to revisit content and directly connect knowledge to real-world scenarios. Therefore, the intervention was effective not only in delivering information, but also in supporting its application in practice. So in conclusion, this mobile application provides a scalable and standardized approach to fire drill safety education in healthcare settings. It supports regulatory compliance with enhancing practical preparedness and confidence among healthcare professionals. And this contributes to improving emergency response and strengthening patient safety outcomes in skilled nursing facilities. And because, as we have seen, effective preparedness is not just about knowing what to do, but about being ready to act when it truly matters. And in this context, building on these findings, it becomes important to look more closely at the nature of the intervention itself. As we know, traditional fire safety training in healthcare settings is often delivered through orientation sessions, lectures, or periodic drills. While these approaches meet regulatory requirements, they are typically time-limited, non-interactive, and often rely on recall rather than real-time application. As a result, learning may remain theoretical with limited reinforcement in day-to-day clinical practice. In contrast, our mobile application was specifically designed to address these limitations. Instead of a one-time training experience, it provides a continuous on-demand access to structured life safety content. And more importantly, it focuses on how to apply knowledge, not just how to remember it. And this approach offers several key advantages. First, it enhances accessibility, as healthcare professionals can review the content anytime directly from their mobile devices. Second, it improves engagement through interactive and scenario-based learning. And third, it strengthens retention and practical application by allowing repeated exposure and direct connection to real-life situations. In addition, the application clearly defines physician roles within the interdisciplinary team, which supports better coordination during emergencies. So overall, this is not just learning tool, it's practical support system for real-world readiness, preparedness. And now to better understand how the application works in practice, let me briefly walk you through it. The user starts with a simple and structured flow. First, they complete a pre-assessment to evaluate baseline knowledge. Then they move through the learning modules, which include visual explanations, key protocols such as raise and pass and real case scenarios. After that, they complete a post-assessment to reinforce their understanding. And finally, they are able to apply this knowledge directly during further simulations or real situations. So the process is simple, structured, and focused on real-world application. And then the application also includes several key features, such as CMS-aligned content, interactive learning modules, rule-focused training, quick knowledge checks, and on-demand access anytime, anywhere, all of which are designed to support post-learning and performance. And for those interested in exploring the application, it can be accessed directly through the following link or QR code. And this allows users to quickly access the platforms and experience the content themselves. I was even directed to the links and so on. So what this demonstrates is a shift from traditional passive training to a more dynamic, accessible, and practice-oriented approach. And this is exactly what is needed to bridge the gap between knowledge and action. And however, while the application provides a solution, it was equally important to evaluate whether this approach actually leads to measurable improvements. And to address this, we developed a structured questionnaire that was used as both a pre-assessment and post-assessment tool. And the aim was to evaluate changes in knowledge, confidence, and practical preparedness. So as we know, effective evaluation requires looking at multiple dimensions. So the questionnaire was designed to cover four key areas. First, demographics to understand participants' background. Second, knowledge, particularly CMS, regulation, and fire response protocols such as READS and PASS. Third, confidence, especially in leadership and response during emergencies. And finally, practical skills, including communication and documentation. So overall, this allowed us to assess both theoretical understanding and real-world readiness. Regarding implementations, participants completed the assessment before using the application, and then again after completing the learning modules, the pre and post intervention design allowed us to directly measure the impact of the app. And in terms of data handling, responses were collected and organized using a structured spreadsheet, allowing clear tracking of each participant's progress. And to analyze the data, we performed a comparative analysis between pre and post intervention scores. We observed a clear improvement in performance with the main pre-test score increasing from 2.08 to 4.62, resulting in a mean increase of 2.54 points. And this improvement was statistically significant with a p-value less than 0.001. And in addition, we observed a significant increase in leadership confidence as demonstrated both in numerical results and graphical analysis. And we also found a statistical significant improvement in REST protocol knowledge. On the other hand, also, although BAS knowledge showed improvement, it did not reach statistical significance likely due to the small sample size. But furthermore, the high baseline performance is in some domains suggests a possible ceiling effect, which may have limited the measurable degree of improvement. So what this demonstrates is that the application is not only effective as a learning tool, but also capable of producing measurable and statistically significant improvements in key areas of preparedness. In other words, this transforms the project from a simple education intervention into an evidence-based outcome-driven solution. And this reinforces the value of integrating digital tools into healthcare training to enhance performance. And in conclusion, as we reflect on this work, we can see that fire preparedness is not simply about knowing protocols, but about being ready to act effectively under pressure. And as we have shown, this mobile application provides a structured, accessible, and scalable solution that supports post-learning and real-world application. And more importantly, it enhances confidence, clarifies rules, and strengthens interdisciplinary coordination during emergencies. And ultimately, this contributes to improving patient safety outcomes in some of the most vulnerable healthcare settings. So this is not just an education tool, it's a step toward transforming how we prepare healthcare professionals for real-life emergencies.
Thank you so much, Dr. Malaz. This is wonderful, excellent presentation, and we are very glad to have you, and congratulations on presenting this in a big conference.
Thank you so much, Dr. Nadir. Actually, I remind someone asked me a question. I remind, even so, I was wrote it
Do not forget it. Let me just found it. Someone asked me regarding what was the most difficult for us. Is it like, wait, let me find the question. Mm. Yeah, was asking me like when we actually like rolled this like app out, what was harder, getting people to use the app or getting leadership to support it? Was asking me this. Actually, I told him, yeah, this is a really good question. Thank you so much. And honestly, like from what we experienced, the bigger challenge was getting people to actually engage with the app consistently more than getting leadership to support it. Because from the leadership side, once they saw that it's aligned with things like CMS requirements and patient safety, they were generally quite supportive. But for users, it's different. Healthcare professionals are already very busy, and adding anything new, even if it's useful, can feel like extra work at first. And so the real challenge was how to make it fit into their routine, not add to their workload. And that is why we focused a lot on keeping the app simple, easy to access, and directly relevant to real situation. And when we noticed is that once people actually starting using it, engagement improved naturally, and because they could see how practical it was, especially during fair drills. So I would say the challenge was more about initial engagement, but once the barrier was crossed, it became much easier.
Yeah, you're right. So I'm gonna just add to that. A few years ago, before the COVID hit, we were working on telemedicine for physicians, and we didn't get much. And as you mentioned, they have a lot on their plate, and the importance of working with computers to see patients remotely, and the payment system, and it's just a very limited adoption by the physician in large. And when COVID hit, it was a flip. It's like turning on a light switch. Everyone jumped on it, and everyone is like, "Oh, it's not that bad. Why we didn't start it in the
Mhm.
past?" And then people get familiar with that, and now they are using it on a daily basis. So, yeah, so you are right. So it's just the initial step for the adopter or the users.
Yeah. Thank you so much, Dr. Nadir.
Thank you so much for sharing. And what did you learn from the conference? Like you made some connections. You said you met some international figures, people from different countries. Anything else that you want to share?
Mm,
Did you look
wallahi,
at other posters, other ideas, other thing got your
mm,
attention?
actually, uh, wallahi, just I noticed like maybe you can literally I noticed like all of them, even so when who's actually talking regarding like other categories, okay, you can say regarding education, or even so regarding the health system, or even so regarding, you can say, treatments plan like medicines and so on, and those talking regarding the operations and so on, all of them, like all of, you can say, word like right now shifting, even so I'm focusing more about innovation, about AI and so on, and mostly of them like was talking regarding their companies and so on, how they started even so integrate the AI and so on, and the like new tools and so on to be updated and so on. So yeah, actually, so when even so like I was talking, most of them like told me, oh yeah, this is literally an innovative tool for the fire drill training and so on. Yeah. So that is why I was felt happy. It was, yeah, actually we are even so yeah, conducted projects, but even so we are updated and we are follow like tools, AI tools and so on, and innovation and so on. So thank you so much, Wallahi, Dr. Nadir.
Thank you so much for sharing this great experience. Thank you. So we can move on to the next section, the update section, and I'm gonna keep you with us, Dr. Malaz. Did you have a chance to look at the project, the spreadsheet? Dr. Malaz, if you are still there.
Sorry, Dr. Nadir.
So we're gonna move to the next step or next item in the agenda, the updates. Anyone wants to share with us their projects? And I know you are going to work on the project for blood pressure and getting studying, getting a group working.
Oh
Do you
yeah,
have a plan?
actually, yeah, I created the group and so on, and I added them. Just I wanted even so to distributed task and so on. Actually, I was just you can say a little busy last days and so on, like to
Yeah,
traveling between
sure.
uh two states and so on. And even so, I got severe migraine. Actually,
Oh,
I'm suffering with migraine. Even so, I didn't respond. I started didn't respond well to the medications. Even so, somatriptan. I don't know what I have to do. So, but actually, yeah, today I think it didn't resolve till now, but I think feel better a little bit. Don't know what I have to do,
yeah, we hope you feel
but
better.
yeah, I will do distribution, inshallah, task distribution, and I will keep you updated. But regarding the RCB, uh, actually before, yeah, before 1 hour, like I did registration for Dana. We complete the registration. Actually, just at the beginning, we faced little bit problem because Dana is graduated, but didn't start her foundation year. I think UK like working with FY1 and FY2 system, and he didn't start. She didn't start the FY1 till now, and just he applied and in order to start next July, I think, and yeah, she applied, and actually just like we have to clarify this in application, but at the beginning she was feel a little bit confused regarding like the options actually in the Google form, because they just giving option of medical schools and option of foundation, like foundation doctor and so on, foundation year. We selected foundation year, and then in job title we mentioned that like if we had applied and shortlisted in order to start in 2026. And regarding the poster, yeah, we're gonna submit it in PPTX. I think I was shared it with you last time.
Mhm.
Um, just regarding, yeah, there was mentioned in the guidelines of the poster, it should be adding this, I think, green square. It should be on the upper left for the poster idea and so on. Just I wanted to check the font sizes again because I noticed even so they mentioned font sizes. It should be like the head, the name of the TGRF. It should be the bigger one, and then the other should be smaller. And the font size itself for the text, all of it, it should be smaller, and it should be less than 10. So I will gonna check this inshallah, and tomorrow morning inshallah we're gonna apply it. But registration for that, alhamdulillah, we finished. And yeah, it's going good, alhamdulillah. Yeah, even so we're gonna help, yeah, inshallah, help her inshallah in presentation. uh, I will do inshallah with her. You can say 2 times or 3 times just to present for me, because she told me that she feel a little bit stressed regarding the presentation and so on. I told her no, it's okay, I'm gonna help you, you can present for me, and I will gonna like give you a reflect and so on, like can help you even so to like train yourself a lot of times and to feel ready even so for that. And yeah, even so I think we're gonna present for the next for the other topic, okay. She told me even so she will gonna proceed and so on. I told her even so, yeah, I can help you, so both you can present for me and I can help you to train yourself for the presentation. So inshallah we're gonna schedule for the training uh, to be ready before presentation time, inshallah.
Sounds
Inshallah.
good.
Thank you very much, Dr. Malaz. Thank you for your time and everything.
Thank
Thank
you,
you.
Aya.
Mhm. So,
I actually you're
yeah, go ahead.
doing a great job. Like she told me even so, just facing little problem with submitting it and so on. And I told her, yeah, you can check with Dr. Nader and so on. Everything gonna be good.
Excellent. Sounds good. So interrupt me if you have any additional information or updates. So I'm gonna share with you one new project. So if you are involved in any research project, that's well and good. If you have extra time or if you are not involved in a research project, we have this idea similar to what we did in the past. In the past, we worked on COPD. We are looking at mobile applications, looking at their features and analyzing that and see if there is a gap and how we can identify these gaps. By the gap, what we mean is we look at the feedback or the reviews, and some of the reviews may show some new features request by the users or the use of AI in this mobile application. So my idea is to apply the same concept. I'm going to share a screen with you. So if you are interested in joining this, this is also analysis of asthma mobile applications in both Google Play Store and Apple Store. If you are interested, please add your name, your email, and you can select any role from here. You can become the project leader if you're interested, or team member, or if you'd like to submit, we can work this as an abstract to a conference, or you can write it as a paper to a journal, or we can move on to create a new app with new features. So I'm gonna share the link with you guys in the chat. If you okay, if I can. Uh, chat. So the link in the chat is linked to this Google Sheet. You can add your name as you are interested if you are, and then you can select the role. So the basic idea, as we mentioned, you can obtain or review the mobile application in the app stores. We can focus on Google or Play Store. You can use different keywords, for example, asthma mobile application or any other indicator to use for asthma, shortness of breath, breathing, and so on. And then you can identify variables or what you want to look at, the total number of users, the positive, negative reviews, and if there are any criteria for you to include or exclude. For example, mobile applications may be published in different language than English. You can include that or exclude that depending on if you speak the language. For example, in French, then you can include. If not, then you can exclude Arabic and so on. The next step, as we mentioned, you can work to get the information and then analyze it and make a post, an abstract to submit to a conference, and hopefully it will be accepted as a poster or oral presentation, like just what Dr. Malaz did in one of the conferences. The other two options, one of them including you can write a long paper or manuscript and submit it to a journal that accept innovation or AI or technology used in medicine. This is one option. The other option is to create a new mobile application if we identify a certain gap or features that are requested by the users of these available apps. So I went ahead and I collected some information using AI about what's available. So for example, there is an app called Asthma Care, and these are the features of that, the downloads, for example, the more than 50,000 and so on. Most of the features are listed. The second app is Asthma Connect and so on. Third app is this one. So you can verify this information. You can add more apps as you find on the stores. Sometimes it will show you it's only in like Play Store, Google, or maybe some of them they have both version, one in Apple Store, one in a different store. This one, for example, is in a different store than the one in Google Store. So, and to identify the lab and the gap, you can look at this, for example, and see what else we can build on. This is just an example of a mobile app idea that you can also, for example, use AI to develop a mobile application. We can use Canva, we can use ChatGPT or Gemini, DeepSeek, or when different AIs available there. My suggestion, for example, Breathe Well app, and this is an example of a link to the app idea or what it will do. The app can be gamified so that most of the kids, if they are using it nowadays, they like to learn through a game approach. It has learning section where it has these features, play section, community section, and so on. So these are features that maybe will make this app unique if we work on it. So whoever interested, please add your name here, and one of you might be a project leader. Mainly the project leader role is to organize, create a WhatsApp group, and then invite others if they are interested. And to do that, you can go to the invitation here. It's a link to the spreadsheet. You can add the new members to the WhatsApp group, and then you can discuss what approach you want to do. You want to focus only on an abstract, you want to do a brief, paper, like a manuscript, or you want to go ahead with developing the new app. There are options for you if you have time to do all three. If you want to focus on just one, that's also absolutely a good thing. We can approach different conferences that work with patients with asthma, or in general in internal medicine, or in pediatric medicine, or in technology and innovation conferences, if we want to only work on an abstract, for example. Same goes for manuscript or journal. We can search when we write the paper, we can find which journal that can accept this type of work. If we go to the route of developing the app, we can use AI to help with developing the app. There are options. One of them is Canva. It's simplified version. The advanced one, we can use Replit. It's user friendly, but it costs some money. And there are other options as well. We can work on getting some of them. Some might be able to help submit the final results if we agree and complete the project to be published in either Google Play Store or Apple Store, or both of them. Or we can make it a simple thing like Glide app mobile application. So let me know what you think. I see there are different fellows who are interested now. I'm going to stop here. If you have questions, please let me know.
السلام عليكم دكتور نادر.
عليكم السلام ورحمة. Go ahead.
Dr. Nadir, I'm interested, but sorry, now I'm driving. I couldn't add my name. So maybe when I arrived, I can add my name. Okay?
Okay.
I'm interested, yes, in
Sounds good.
joining one of the projects.
Okay.
I would like to thank all the speakers today. It's very informative and very good presentations.
Thank you so much, Dr. Noon. I'm going to add your name to the list.
Yes,
and,
please.
Yeah. Okay. Any other updates? Any other questions? I know maybe there are some few new fellows.
Dr. Nader, actually, I remind something.
Yeah.
During the conference, even so, after the presentation and so on, I don't know regarding the comments, like, and the evaluation of the participant and so on, but the organizer committee, actually, they was contacted me and they actually asked me if I can even so present the the project and so on, even so again in the conference in the virtual as virtual presentation during the third day, I think. And like they was give me even so like virtual slot for the presentation and so on. And yeah, it was on 22 or 23rd. Yeah, I was presented it even so virtually. Okay. And they was even so told me they were gonna give us a free slot in the in-person slot in the upcoming conference, inshallah, of the 2027.
Oh, wonderful. That's great.
Yeah.
That's good news. Yeah.
Yeah, and yeah, and actually even so, Yesterday they told me like regarding the last conference book and so on, they will gonna share it with me, inshallah.
Oh, excellent. That would be great as well. So we'll have a look at what you did and other stuff. But thank you so much for this
Thank
great,
you, so Dr.
yeah,
Nadir.
yeah. Thanks for sharing, and it's an important aspect. So in the past, we did similar things with Alzheimer conference, where also one of the fellows did a great job, like what you did, and they gave her 1 year membership, and we submitted next year for the conference, and we were also successful in getting some of the posters accepted. So thank you
Yeah,
so much.
thank
Yeah,
you so much. Thank you.
and this indicates how hard you work and your job and the impact of what you did. Thank you.
Thank you so much.
Thanks. Any questions, guys? Any comments, new ideas for new projects? Any thing unclear for new fellows or?
Yeah, Dr. Nadir, just I wanna like just share for all of like just as alarm you can say, oh, why all of us just pay attention regarding the when we add our names and so on to the abstract, you can say uh or add our names to the manuscript or whatever the research paper and so on and submit it in, because I was just faced a little bit problem regarding when of our team after submitting the abstract and so on, regarding all of this time between finishing the abstract and submitting to the conference, suddenly he discovered his name, like his first name is wrong and so on, it should be starting with A and so on. And this actually led me to getting just in little bit issues regarding I have to verifying, I have to share again I have to contact the PR actually of the conference and so on, and told him regarding our issues and his name it should be correcting and so on. It should, and like they asked me even so, the PR asked me even so to verify that I I was shared the abstract and so on, and I was shared all the names and so on, and they told me that okay, they will gonna verify regarding the issues, and then if we're gonna see if we can correct the name and so on. And I was even so give him a lot of, you can say, clarification regarding the issues. He was actually changed his name in the abstract after even so we submitting it and so on, and we received the letter of acceptance and so on. And I was, you can say, he was putting me just in option to clarify for them. This was unintentional and so on. There isn't a problem and so on. It was submitted wrong and so on. And like it should be corrected and so on, because in errors and so on, they will gonna be like back to the conference book and so on, and it should be verified and so on. Yeah, and they asked me, okay, share the abstract, the main abstract and so on. I was shared and so on. And they told me, okay, we're gonna see if we're gonna check, we're gonna edit it and so on. But alhamdulillah, maybe actually even so, they was good and so on. Committee, then after that they accepted. They contact me back, and then they told me, okay, we're gonna change it in the form, submitting form, and even so we're gonna correct it in conference book. But please, we have all pay attention regarding our names in the research paper, our names in abstract and so on, because who will gonna present and or who will gonna submit, we're not gonna, you can say, focus will always all names and so on, but you as author and who also the project leader should pay attention a little bit regarding these issues.
Great. Yeah, it's a great point. And I think we come across the same problem with when we submitted to a different conference, and now we are working on getting that corrected. So I think we need to, as you said, the submitter and the leader of the team need to verify with the authors included and get their names corrected before submission. If it's submitted, that means the authors themselves were not paying attention or they did not contribute enough in time to make it happen. So I think when we start, like we're starting this project right now, I think when we ask people to put their names, I think they need to pay attention that their names are valid names and correct names so that the author, when they collect this as authors in the abstract submission process, they use these names. But thank you so much for clarifying this, and it's an important point. So if there are no more questions or comments, any ideas, we will see you next week. I'd like to thank you all presenters from today's meeting. Great job. Thank you for sharing your work. Dr. Wala, want to add something? Not. Then I'd like to thank you all for attending this meeting. And I'd like to thank those who will come and watch the recording in the future. See you next week. Have a wonderful day. If you have questions or any concerns, comments, new ideas, please reach out. You can email me, you can text, WhatsApp, or call me. I'll be happy to assist and help as much as we can. Thank you, and we'll see you next week. Assalamu alaikum.
Walaikum assalam. Thank you, Dr. Nadia.
Thank you, Dr. Azza.